Right now, as you are listening to this, millions of adults over 60 are opening their medicine cabinet, shaking out a vitamin B12 tablet, and swallowing it with a glass of water, just like they have done every single morning for months or years. They are being responsible. They are doing exactly what they were told. And for far too many of them, that B12 is doing almost nothing. Not because they are taking too little, not because of their diet, because of the form they are taking, and because of something happening inside their digestive system, something that begins to change the moment we pass 60 that most doctors never explain. Before anything else, I want to be clear, everything in this video is educational information only. It is not medical advice. Nothing here replaces the guidance of your own doctor. Always work with your healthcare provider before making changes to your supplement routine. A study published in the American Journal of Clinical Nutrition found that between 40 and 43% of adults over the age of 60 have subclinical B12 deficiency, low enough to affect neurological function even when they believe they are supplementing adequately. 40 to 43%, nearly half, and many of them are taking B12 every single day. This is not a deficiency problem, this is an absorption problem, and it is one of the most misunderstood issues in senior health today. Stay with me until the very end of this video, because number one on the list I am about to share with you is the single most overlooked reason B12 supplementation fails in adults over 60. And once you understand it, everything about how you approach this vitamin will change completely. I am Dr. Andrew Carter. I have spent over 15 years working exclusively with adults over 60. I have worked with people who came to me numb in their fingers, unsteady on their feet, unable to concentrate, exhausted to their bones, all while showing me a B12 bottle they had been taking faithfully for 2 years. What I am about to share goes against what many standard approaches to supplementation will tell you, but I have seen it happen patient after patient, and I refuse to stay quiet about it any longer. If this channel is new to you and you want clear, honest information about what is really happening inside your body after 60, hit that subscribe button right now. Every week I come here with one purpose: to give you information that actually makes a difference. Now let me explain what B12 is actually doing in your body, because most people know it supports energy and nerve health, but B12 is doing something far more specific than a general energy boost. Vitamin B12 plays a central role in maintaining the myelin sheath. This is the protective layer that wraps around every nerve fiber in your body the same way insulation wraps around an electrical wire. When myelin is healthy, nerve signals travel fast and accurately. When myelin begins to degrade, those signals slow down. They misfire, and the symptoms that follow are things many adults over 60 assume are just aging. Tingling in the hands and feet, numbness, brain fog, balance problems, memory lapses, fatigue that sleep never fully fixes. B12 is essential for producing the compounds that form myelin. Without adequate B12, that production breaks down, homocysteine accumulates, and myelin repair slows or stops. A study published in the journal Neurology found that adults over 65 with low B12 showed measurable reductions in myelin density in key brain regions associated with cognitive decline, slower processing speed, and impaired motor coordination. Here is what makes this complicated. Your B12 level on a standard blood test can look normal, while your nervous system is still being starved. Standard serum B12 measures total B12 in the blood, including inactive bound forms that cannot reach nerve tissue. The sensitive markers methylmalonic acid and homocysteine tell a far more accurate story, but most adults are never tested for those. Before we go into the list, type in the comments what form of B12 you are currently taking: cyanocobalamin, methylcobalamin, sublingual drops, or a standard tablet. Because by the end of this video, you will know exactly whether what you are taking is actually reaching your nervous system. Number 10, taking B12 in massive doses and assuming size equals absorption. You look at your bottle and it says 1,000 micrograms, maybe 2,500. The recommended daily intake is just 2.4 micrograms. How could you possibly be deficient? Here is how. The primary pathway for standard oral B12 requires a protein called intrinsic factor produced in the stomach, binding to B12 in the small intestine, and carrying it through the gut wall into the bloodstream. Without intrinsic factor, most of the B12 in a standard tablet is excreted. The only reason high-dose tablets work at all is that 1 to 2% of B12 can be absorbed passively without intrinsic factor. A 1,000 microgram tablet might deliver 10 to 20 micrograms, above the minimum, but nowhere near what someone with depleted stores actually needs. A study published in the European Journal of Clinical Pharmacology found that absorption efficiency for standard cyanocobalamin drops by as much as 40% from age 40 to age 70, driven by declining stomach acid and intrinsic factor availability. The number on your bottle is not what you are absorbing. Number 9. Relying on dietary B12 without accounting for how age changes your ability to process it. B12 in food exists in a protein-bound form. Your stomach needs hydrochloric acid and enzymes to break those bonds and release it. Studies in the Journal of Gastroenterology show that by age 70, up to 30% of adults have significant reductions in stomach acid secretion. Two people eat the same meal. One absorbs 70% of the B12. The other absorbs 15. The difference is not what they ate. The difference is the acidity of their stomach. If you are over 60 and relying on food-based B12, ask your doctor for a methylmalonic acid test, not just serum B12. MMA rises specifically when cells do not have enough active B12, even when serum B12 looks normal. Number 8, taking B12 at the same time as things that destroy it. High-dose vitamin C taken simultaneously with B12 has been shown to break down cobalamin in the digestive tract before it can be absorbed, reducing availability by up to 30%. Antacids taken within an hour of B12 raise your stomach pH at exactly the moment your gut needs to be acidic. Take your B12 alone, before coffee, before other supplements, before anything that alters your stomach environment. Give it a clean 30-minute window. Number 7. Never checking your homocysteine, the blood marker that reveals the real cost of low B12. Homocysteine is an amino acid that accumulates when B12 is insufficient. B12 and folate work together to convert homocysteine back into methionine. When that conversion slows, homocysteine builds up, and elevated homocysteine is not harmless. A meta-analysis published in the American Journal of Medicine found that elevated homocysteine is associated with a 64% increased risk of cognitive decline and dementia in adults over 65. 64%. Nearly 2/3 of an increased risk from something measurable on a blood test and correctable with the right form of B12. Ask your doctor for a homocysteine test at your next B12 check. If it is elevated above 10 to 12 micromoles per liter and your B12 is in the lower half of normal range, you have a functional deficiency regardless of what the serum B12 number says. Type the word homocysteine in the comments right now if you are hearing about this for the first time, and share this video with one person over 60 in your life who takes B12 every day. What they learned today could protect them. If you have not yet subscribed, do it now and ring the bell so you never miss what I bring here every week. I want to tell you about Patricia. Patricia was 74 years old. Retired teacher from Nashville, Tennessee. She had been taking 1,000 micrograms of cyanocobalamin every single morning for 3 years. For the last 8 months, she had a constant tingling in her feet, persistent, there when she woke up and still there at bedtime. Her doctor ran a standard panel. B12 came back at 312 picograms per milliliter within normal range. She was told she was fine. Patricia was not fine. I asked 2 questions her previous doctor had not. First, what form of B12 are you taking? Cyanocobalamin. Second, are you on medication for acid reflux? Yes, a proton pump inhibitor. For 4 years, a PPI reduces stomach acid production. That is its job, and in doing it, it had systematically eliminated Patricia's ability to absorb B12. Her serum B12 looked acceptable because inactive, bound B12 was still circulating. But her cells were not getting it. We switched her to sublingual methylcobalamin dissolved under the tongue, bypassing the stomach entirely. We added folate to support the homocysteine pathway. Within 3 weeks, the tingling began to reduce. 6 weeks in, nearly gone. 3 months later, Patricia told me it had vanished completely. She said, I thought that was just what getting old felt like. I thought I had to live with it. This was not a miracle. This was biochemistry. Her nerve tissue finally received the B12 it had been waiting for. And the same option is available to you. Number 6. Taking the wrong form and why the difference between cyanocobalamin and methylcobalamin is not a minor detail. Cyanocobalamin is the synthetic form in most mass-market supplements. Inexpensive, stable, and the form found on almost every pharmacy shelf. But cyanocobalamin is not the active form your body uses. Before it can do anything useful, your liver must convert it into either methylcobalamin or adenosylcobalamin. In adults over 60, particularly those with reduced methylation capacity, that conversion is less efficient than it once was. Methylcobalamin is already in the active form. No conversion needed. It can be used directly by nerve cells and brain tissue the moment it is absorbed. A study published in the Journal of Neurological Science found that patients with peripheral neuropathy, tingling and numbness in the extremities showed measurable improvements in nerve conduction velocity with methylcobalamin that were not observed with equivalent doses of cyanocobalamin. Check your label. If it says cyanocobalamin, consider switching. The cost difference is minimal. The biological difference can be significant. Number 5, taking medication that depletes B12 without realizing it, and this is the item on this list that concerns me most. 2 categories. First, metformin, one of the most widely prescribed medications for type 2 diabetes. Metformin blocks calcium-dependent receptors in the small intestine that are involved in intrinsic factor B12 transport. A study published in the Archives of Internal Medicine found that long-term metformin use is associated with a 19% reduction in B12 levels, and the longer the use and the higher the dose, the greater the depletion. Second, proton pump inhibitors. A study published in the Journal of the American Medical Association found that adults taking PPIs for 2 or more years had a 65% higher risk of B12 deficiency compared to non-users. 65% higher risk from a medication tens of millions of adults over 60 take every single day. If you take metformin, a PPI, or both, ask your prescribing doctor specifically about methylmalonic acid and homocysteine testing, and whether sublingual or injectable B12 would be appropriate for you. I want to tell you about James. James was 78 years old, retired engineer from Cincinnati, Ohio, 11 years on metformin for type 2 diabetes. He came to me because of cognitive changes his family had noticed about a year earlier. Slower to respond in conversation, losing words mid-sentence, always exceptionally sharp and detail-oriented. Now his family was frightened. His doctor had checked his B12. It came back at 278 picograms per milliliter, low normal range. Age-related, he was told. I ran his methylmalonic acid. It was elevated. His homocysteine was over 16 micromoles per liter. His cells were not getting effective B12. The standard serum test had completely missed it. We worked with his prescribing physician to add sublingual methylcobalamin and methylfolate. 6 weeks in, his family noticed he was more present in conversation. 3 months later, James told me the fog lifted. His word finding improved. His homocysteine dropped from over 16 to 9.2. This was not age. This was a correctable deficiency masked by a medication that no one had ever monitored him for. And it exists right now for millions of adults on metformin who have never had their MMA or homocysteine checked. Number 4, not understanding intrinsic factor, the protein your body is silently producing less of after 60. Intrinsic factor is produced by parietal cells in the stomach lining. It binds to B12 in the small intestine and carries it through the gut wall into the bloodstream. Without it, standard oral B12 absorption is reduced by up to 99%, and parietal cell function declines with age. A study published in Frontiers in Aging Neuroscience found that intrinsic factor secretion was measurably reduced in 35 to 40% of adults over age 65. Most of them had no idea it was happening. This is why sublingual B12 matters. The mucous membranes under the tongue have a direct blood supply. B12 absorbed sublingually enters the bloodstream directly, bypassing the stomach and intrinsic factor entirely. For anyone with declining parietal cell function, sublingual is not a preference. It is a necessity. Number 3, taking B12 at the wrong time and under the wrong conditions. Standard tablets absorb best with a light meal that triggers acid and enzyme production. But for adults with low stomach acid common after 60, even timing optimization may not be enough. A study published in the British Journal of Clinical Pharmacology found that sublingual forms showed the least absorption variability regardless of timing, while standard tablets showed the most variability, same dose, completely different outcomes depending on digestive status. The simplest protocol for adults over 60, sublingual methylcobalamin in the morning before coffee or food. Hold it under your tongue for 60 seconds before swallowing. That contact time with the mucous membranes maximizes direct absorption before anything reaches your stomach. Number 2, choosing a tablet over sublingual delivery without understanding what that choice costs your nervous system. A standard tablet, even 2,500 micrograms of cyanocobalamin, travels through your entire digestive system before any absorption can occur. Every step depends on conditions that deteriorate with age. Sublingual B12 bypasses the stomach completely. No stomach acid required. No intrinsic factor required, no liver conversion for methylcobalamin. A comparative study published in the Canadian Family Physician found that high-dose sublingual B12 can achieve blood levels comparable to intramuscular injection, while standard cyanocobalamin tablets consistently underperformed on cellular B12 markers in adults with any degree of absorption impairment. In adults over 60 with compromised absorption, a standard tablet may deliver 10 to 20 micrograms of usable B12. A sublingual equivalent dose may deliver 40 to 80. 2 to 4 times more. In a nervous system that has been running low for months or years, that difference determines whether your nerves start recovering or continue to degrade. And now, number 1, the most overlooked, most underdiagnosed, most silently damaging reason B12 supplementation fails in adults over 60. Number 1, reduced stomach acid and the cascade it sets off through every layer of your B12 absorption pathway simultaneously. This is the root of everything. By age 70, a condition called hypochlorhydria, chronically low stomach acid, affects an estimated 30 to 40% of older adults. Here is what it does at every level at once. First, low stomach acid fails to release protein-bound B12 from food. The The B12 in meat, fish, eggs, and dairy stays locked inside food proteins because the acid needed to break those bonds is not there. Second, low stomach acid means the parietal cells producing acid are also producing less intrinsic factor. Even if some B12 is released, there is less intrinsic factor available to carry it through the intestinal wall. Third, low stomach acid changes the bacterial environment of the gut. Without adequate acid, bacteria colonize parts of the upper small intestine where they do not belong, and some of those bacteria consume B12 before it can be absorbed. All three mechanisms at once in a body that may already be on a PPI, further reducing acid. In a body that may be on metformin, blocking the final transport step. Not one obstacle, a layered system of obstacles. A study published in the Annals of Internal Medicine found that adults with confirmed hypochlorhydria absorb just 15 to 25% as much B12 from food and standard oral supplements as adults with normal stomach acid, a reduction of 75 to 85%. The difference between a nervous system that is nourished and one that is being slowly, quietly starved. And the most devastating part, hypochlorhydria is largely asymptomatic. You may have no idea it is happening. The tingling, the fog, the fatigue, the balance issues come years later after the deficiency has been accumulating invisibly. Ask your doctor to test three things: serum B12, methylmalonic acid, and homocysteine. All three together give you the complete picture. And if you are supplementing, switch to sublingual methylcobalamin. Not next month, not when you finish your current bottle. Today, I want to tell you about Linda. Linda was 71, retired librarian from Seattle, Washington, bone-deep fatigue for 2 years, needing to rest by 10 in the morning, asleep again by 8 at night. She had lost interest in reading, which for a retired librarian was, in her words, like losing a piece of herself. Her doctor ran a full panel: thyroid normal, anemia negative, B12, 290 picograms per milliliter, aging and depression, he concluded. Antidepressants were offered. Linda declined and came to me instead. She was not on metformin or a PPI, but she mentioned she had been told years ago she had mild gastritis. Mild chronic gastritis over time is a primary cause of parietal cell degradation, reduced intrinsic factor, reduced stomach acid. Her MMA was elevated, her homocysteine was elevated, her cellular B12 status was poor despite a normal-looking serum level. We began high-dose sublingual methylcobalamin, 1,000 micrograms every morning dissolved under the tongue, alongside methylfolate and B6. At 3 weeks, Linda was making it to noon before feeling tired. At 6 weeks, she was taking afternoon walks. At 3 months, she told me she was reading again, a full book a week the way she used to. She said, "I gave up on myself. I thought this was just the end of feeling like me." It was not the end of anything. It was her body finally getting what it had been asking for, and the same is available to you. Before the action plan, scroll to the comments and type the number of the item that hit closest to home. Was it number 5, the medication? Number 1, stomach acid? Number 6, the form you have been taking? Drop your number. I want to see it. If you have been watching and have not yet subscribed, tap that button and ring the bell. And share this video with one person over 60 in your life who takes B12 every day and has never heard of intrinsic factor methylcobalamin or methylmalonic acid. You might be handing them their cognition back. Here is your action plan. Starting today. Step 1. Check your label. If it says cyanocobalamin, plan to switch to methylcobalamin. Step 2. Find a sublingual form, a tablet that dissolves under the tongue, a liquid or a lozenge. Sublingual delivery bypasses the stomach and intrinsic factor entirely. Step 3. Ask your doctor for a complete panel: serum B12, methylmalonic acid, and homocysteine. All three. A normal serum B12 with elevated MMA or homocysteine means functional deficiency. Step 4. If you are on metformin or a PPI, have an explicit conversation with your prescribing doctor about B12 monitoring and whether sublingual delivery is appropriate for you. Step 5. Take your sublingual B12 in the morning. Hold it under your tongue for 60 seconds, before coffee, before other supplements, before antacids or high-dose vitamin C. At 3 to 5 days, many people notice a subtle lift in morning energy. The first sign cells are receiving usable B12. By 2 weeks, sleep quality often begins to improve. By 4 to 6 weeks, early neurological symptoms often begin to reduce. By 3 to 6 months, cognitive improvements become measurable as homocysteine normalizes and myelin maintenance resumes. Now, let me talk about the 5 mistakes I see most often. Mistake number 1. Trying to change everything at once. Buy one thing: sublingual methylcobalamin. Run it for 4 weeks. Then add the next step. You cannot measure what you cannot isolate. Mistake number 2. Switching to methylcobalamin and quitting after 2 weeks because you do not feel different. Neurological repair takes time. The myelin sheath does not regenerate in 14 days. If you have been deficient for months, recovery takes months. The change is happening before you can feel it. That is not failure. That is biology. Mistake number 3, accepting a normal serum B12 as the complete answer. If your doctor says you are fine based only on serum B12, ask specifically for methylmalonic acid and homocysteine. Do not leave that appointment without those numbers. Mistake number 4, taking B12 without pairing it with folate. B12 and folate work together in the homocysteine conversion pathway. Look for a supplement that pairs methylcobalamin with methylfolate, the active form that requires no conversion in your body. Mistake number 5, feeling shame or blame about where you are. The problem was never you. The problem was broken information. You were handed a synthetic vitamin in a tablet and told it was enough. You were never told about methylcobalamin. You were never told about intrinsic factor. You were never told about methylmalonic acid. You were doing your best with what you had. Now you have better information. That is all this ever takes. Let me give you the full picture one more time. Number 10. High-dose standard tablets can still fail because the absorption pathway they depend on has been compromised by age. Number 9. Dietary B12 requires stomach acid to release it from food, and stomach acid declines meaningfully with age. Number 8. Vitamin C antacids and other supplements taken simultaneously can break down B12 before it reaches your bloodstream. Number 7. Homocysteine is the marker that reveals the real cost of functional B12 deficiency, and most adults have never been tested for it. Number 6. Cyanocobalamin requires liver conversion to become active. Methylcobalamin is already in the form your nerve cells can use. Number 5. Metformin and proton pump inhibitors, 2 of the most common medications in adults over 60, both significantly deplete or impair B12 absorption. Number 4. Intrinsic factor production declines with age, progressively removing the primary pathway through which standard oral B12 is absorbed. Number 3. Timing and conditions of supplementation make a measurable difference in how much B12 actually reaches your cells. Number 2. Sublingual delivery bypasses the stomach, the acid requirement, and intrinsic factor, delivering B12 directly into the bloodstream regardless of your digestive status. Number 1. Low stomach acid is the silent root cause that makes every other absorption problem worse, and it accumulates invisibly for years before symptoms appear. Commit to just 3 changes, not all 10. 3. For the next 30 days. 1. Switch to sublingual methylcobalamin. Today. 2. Ask your doctor for methylmalonic acid and homocysteine testing at your next appointment. 3. If you are on metformin or a PPI, tell your prescribing doctor you now understand the B12 depletion risk and you want a monitoring plan. 3 changes, 30 days, then come back and tell me in the comments what you noticed. Your nervous system has been working for you your entire life. Every nerve signal, every heartbeat, every step you have ever taken, all of it carried by a network of fibers that have been asking quietly for the nourishment they need. They are still asking. They are still repairable. The window is not closed. You are not broken. Your nervous system is not broken. The information you were given was broken. If this video opened a door that has been closed for too long, share it with someone who needs to walk through it too. Join this channel if you have not yet, because every week I come back here with one purpose: to give you the information that helps you stay sharp, stay strong, and stay fully yourself. Aging does not take away your body's ability to recover. It simply reminds you to care for it the right way. Take care of yourself.